The aim of regional analgesia is to provide effective pain relief to labouring women whilst maintaining sensation and mobility. Regional analgesia is suitable for the vast majority of women. In the small number of cases where it is absolutely contraindicated, it is wise to discuss alternative methods of analgesia with a member of the anaesthetic team. There are some conditions that may require additional investigations to be undertaken prior to a decision to site an epidural. These are systolic pressure greater than 160 mm of mercury, diastolic pressure greater than 100 mm of mercury, diastolic pressure greater than 95 mm of mercury plus proteinuria, unstable blood pressure, other convincing symptoms of PET, worsening medical condition, HELP syndromes, abnormal liver function, platelet count of less than 100 or falling platelet count, and any disorder of clotting. If any of these criteria are met, please discuss what additional haematology investigations are required and explain to the woman that there may be a delay in siting the epidural whilst awaiting results. Once in place, drugs will be delivered by the CME Bodyguard pump. The infusion is provided in pre-packed 100 ml bags containing fentanyl and bupivacaine, otherwise known as low-dose mix. This is a controlled drug and must be signed in and out by 2 registered healthcare professionals. The epidural pump has 3 pre-programmed protocols. Protocol A provides a continuous infusion with a patient bolus available on demand. The patient bolus is delivered over 30 seconds each time the woman presses the patient button. This bolus has a lockout of 20 minutes to avoid overdose of the low-dose mix, and therefore is only available when the button glows green. Once the pump is set up and ready to use and the giving set has been primed, it is time to connect the giving set to the patient. It is imperative that either 2 midwives or a midwife and anaesthetist witness the connection of the giving set to the epidural catheter. Particular care should be taken that the connection is correctly done. There have been previous cases of the inadvertent connection of the low-dose mix to a peripheral IV cannula. This has potentially severe consequences for the woman, including cardiac arrest. Once connected, the infusion can be commenced by pressing the start button. It is good practice to check the connection between the giving set and epidural catheter at this point to ensure there are no leaks. Other protocols are available on the pump. However, these are non-standard protocols and should not be used without the direction of a consultant anaesthetist. The goal of epidural management is to maintain a block height of T8 to T11 in the first stage of labour, whilst maintaining adequate pain relief for the woman. Once analgesia has been established and the infusion commenced, the following regular observations should be recorded. Every 30 minutes, pulse, blood pressure, respiratory rate, fetal heart rate, and every 60 minutes, the same observations again, plus motor block, sympathetic block, sensory level, and infusion rate. If a separate clinician bolus is delivered, it is important that maternal observations are recorded every 5 minutes for the following 20 minutes and are recorded on the epidural care plan. Whilst the risk of harm from an epidural remains very low, you must stop the infusion and summon urgent assistance if any of the following occur. Maternal pulse of less than 60 beats per minute, respiratory distress or a respiratory rate of less than 8 breaths per minute, systolic blood pressure of less than 90 mm of mercury, sensory level higher than T6, any concern about sedation, or a sudden onset of dense motor block. Whilst waiting for help to arrive, consider administering high-flow oxygen via a non-rebreathe face mask, turning the woman to a left lateral position, increasing intravenous fluids, and asking a colleague to obtain the cardiac arrest trolley.